The term therapeutic layering is kind of a new term, but actually the concept is old. We talk about combination therapy, starting a couple different therapies together. What therapeutic layering is when you're on one agent already and you add another agent on top. And if you think about it, prostate cancer is a perfect example where therapeutic layering is commonly done. A patient can't develop castration-resistant prostate cancer without progressive disease while on standard androgen deprivation therapy. So when someone develops castration-resistant prostate cancer, they remain on their LHRH therapy chronically, lifelong. Whatever else you add on is therapeutic layering. Now, this term became more popular recently as as physicians and providers were using Radium-223 and being layered on top of drugs like abiraterone and enzalutamide. Now, there's no data to show that that's the right approach, no data to show that that's the wrong approach. There's obviously some data with ERA-223 right now that has individuals concerned about fractures and deaths with the combination of radium and abiraterone. But keep in mind, those were combinations started together. It wasn't layering. And we have yet to see data from the PEACE trial where we'll see combination data with radium-223 and enzalutamide. So again, therapeutic layering is just adding one agent on top of another, and there's outstanding long-term precedence of that with adding agents in castration-resistant prostate cancer on top of LHRH therapy. But going to the next level, we'll have to wait and see. There's not a lot of trials that are addressing that.
Radium-223 was approved based on a randomized phase 3 trial where inclusion criteria for patients included patients who had disease progression on docetaxel chemotherapy or who could not tolerate docetaxel or who refused to be on docetaxel chemotherapy. Based on these criteria, I use radium in those patients who have either progressed on docetaxel or cannot tolerate docetaxel or have refused docetaxel. So in my practice, a patient who has bone metastasis in castration-resistant metastatic prostate cancer setting and has bone pain, I would use radium.
Administration of radium following chemotherapy is fairly standard. There is adequate safety and efficacy data, especially because the registration trial, the ALSYMPCA trial, included those patients. About half of the patients on the ALSYMPCA trial were post-docetaxel therapy, so they had already received chemotherapy, shown signs of progression, and then were enrolled on the study. Following Radium-223, whether to give chemotherapy, whether there is increased adverse events, so far all of the experience that has reported on this has shown that there is no increased incidence of adverse events found with using chemotherapy after Radium-223. Even on the ALSYMPCA trial, about 17% of the patients went on to get chemotherapy and there were no adverse events reported. So Radium-223 was evaluated initially in the ALSYMPCA trial as in comparison with placebo. This was a double-blind randomized trial, and the maximum number of doses that were chosen for that study was 6 for Radium-223. Since then, there have been studies looking at randomizing patients to receive the standard dose versus a longer time period of up to 12 doses or a higher dose of Radium-223. That study, however, showed that the higher dose or the longer duration did not seem to add anything to patient outcomes. So at this time, it cannot be recommended to extend the treatment beyond 6 doses.